Well, good morning, everyone. My name is Ing Ho, and I am, as Dr. Jan mentioned, I've been in health IT for the last 25 plus years, and I've had the good fortune of actually seeing quite a number of things as they've developed over this very young industry. I actually started my career as an emergency medicine physician, and then I actually went to business school in 98 to 2000. So if you think about it, that was during the dot-com boom, which was probably the best time for me because it allowed me to step into a series of innovative companies, small and large, and actually have the opportunity to play a lot of different roles. And also deal with a lot of the assumptions that people were actually facing with when we had no digital infrastructure and were trying to create a digital infrastructure. I also call myself an AI humanist, which is it seems a little odd that I throw that up there, but I throw that up there because generative AI is an area that I think many people are talking a lot about, trying to integrate it a great deal into the health information technology digital infrastructure. But there's a way to do it, and then there's a way not to do it. And I think that there's an argument to be made that what are the purposes of AI if not to basically preserve human dignity and agency and also enhance and augment the qualities and capabilities of human beings who are involved in the healthcare industry. And then lastly, I have a book coming out next month that talks a lot about the legacy that health IT has sort of left behind and kind of what that means for a road to responsible AI. I thought maybe since it's a business school class, I'd throw it out and be a little more interactive and ask some questions. So I imagine many of you have been thinking, and obviously you've been listening to lectures about this, is why do you think the health information technology infrastructure doesn't really work? Like, why is it not like banking or finance or media or entertainment? What do you think is the reason?
I mean, two definitely would be regulation, privacy-related regulation, and then the long history of non-digital processes and storage and organization. So working that out to replace with digital, in addition to regulation, can be really tough.
Okay, good. So regulation, lack of sort of some process in the place, and then difficulty in sort of making that changeover from work. So, any others?
Patients use several providers, and then each of those providers might have their own technology, so then it makes it tough for it to be all.
Siloed information, right? I see one doctor out of the Cornell system, I see another physician out of NYU Langone, I see another concierge physician, all my information in different places.
Different stakeholders might see health data as some competitive asset rather than something that can be easily shared. For example, like health systems, they might withhold some of the data just because it benefits them competitively.
Do they use their data to run their operations? Why should they give it up, right? So these are all good answers, and all of them are kind of correct, right? Because if you think about health information technology or a digital infrastructure, why would you ever want one? Well, you want one because there's lots of information, there are lots of people in the system, there are various stakeholders, like you said, with their own perspective. You have to track progress, and you're generating data all the time, and you're also generating transactions every second. So what do you need all that data and analysis for? Well, you need it not just to diagnose conditions and manage care, but you also need it to get paid. And you need it to support research and evaluate systems and allocate resources and meet compliance. So in a large respect, it seems like we should have a system that works better because after all, we have a great need for it. We have all of these things going on. So let me ask you another question. How easy is it for you to get your own medical records? Who's tried to do it? What was your experience like?
I got denied or come in person. I'm living in New York when I moved to New York, I tried to get my medical records moved to my new physician. And they're like, you have to come in person. Then they sent me to the main hospital. It was like a maze to even try to get access to my records.
So basically you had to stand outside of a room, right? Wait for someone to print it for you, maybe even burn it on a DVD, and then hand carry it to the next place that you needed to, hoping that they would download it somehow and then be able to read it at some point. Pretty typical.
like a slightly different angle, but I worked at a hospital this summer and sometimes I sat in an administrative building next to their records like phone line. And even the people managing that had trouble accessing records and like finding the right information for the patient who was calling.
So were they having also trouble finding like x-rays and maybe also
Yeah, and like
reports of any sort and
getting
labs,
the right information.
getting it all together, right?
I feel as like, I do think it's hard to get like medical records in general. I do think there are like starting to be more integrations with like your phone and stuff like that, where you can have the data on your like available to you in through, I know like Quest did it for a while, where you could like integrate it with your like your Apple Health or so on, you can see your like data there. But in general, it's still pretty frustrating.
Right, and the operative word that you used is somewhat, right? You can somewhat get it, right? Everyone can somewhat get some of their data, but you've just listened to multiple lectures about integration, right? Like we're integrating. Why is it so difficult, right? In theory, we've put billions of dollars behind trying to put records and systems and the ability to capture all this information in order to try and drive better health outcomes, and yet you're still having trouble getting your data, right? And all the rights, you have all the rights to do it. All the legislation that has passed in the last 20 years has all been about the rights that you have, and the difficulty that you are all experiencing is unfortunately the reality on the ground. So why is that? That's because health IT exists within the US healthcare system, okay? Now I know that sounds kind of cryptic, but you have to understand that the US healthcare system, lots of people talk about it as broken, disaggregated, disparate, fragmented. It actually has a number of structural impediments that are often at cross purposes. And the biggest one of all actually tends to be around patient privacy. So we're going to talk a little bit about patient privacy and why something so fundamental could be so much of a challenge in terms of information systems. So we're going to unpack this a little bit more, because when I wrote that last slide, I know you're all probably thinking, well, that's kind of obvious, not too exciting there. There's one thing I think that everyone should take away today. This is just one thing, which is that you have to understand policy before you understand the business of healthcare. There is really no other way to describe this particular industry. If you don't understand the policy, meaning you don't understand what the legislation, what the different policy aims are that govern whatever you're dealing with, you won't really understand why there's behavior that you have amongst all the people within the market, or within basically the entities within a market. And so these are some topics here, from patient privacy, infrastructure building, interoperability, electronic records, which we'll spend more time with today, certification, clinical trials, patient data, real world evidence, generative AI. All of these things are underpinned by a sense of understanding what was the policy implication or the policy desire that allowed things to play out the way that they have. And you could almost argue that every one of these things have a problem, okay? And largely because of the fact that many of these different initiatives really had to contort to figure out how to work within, and I forgot who here mentioned regulation. There are a number of things that that became part of this. So why don't I start off by giving you a little bit of a history of electronic records. And this is, I imagine you have probably seen something like this before. But it's funny about how we think about electronic medical records. In the very beginning of electronic medical records, in the 1960s, Mayo Clinic wasn't the only one. It is written down as the first large health system to actually use an electronic record. But there are a number of academic institutions around the United States who are actually employing the beginning of what they would consider electronic records. But a lot of them were so expensive that they were all done as part of government initiatives, just trying to pull pieces of information together. What was remarkable was that in 1972, the first electronic record was sort of developed at Reagan Street Institute, and this was headed up by Clem McDonald, who was a physician who believed very much that he was tired of getting information from one department to another, and thought, well, if nothing else, let's just make it a central repository where we can get all this information. So if you think about it, most of what electronic medical records were in the very beginning were just electronic file cabinets. We just need a place to store this. We just need a place to be able to go find it. We're tired of running around to go get it. There's obviously a lot of information. We're making mistakes because we don't know where a piece of paper might exist. But since electronic is easier to store, that's what we're going to do. It was very much an engineering problem that we were trying to use, or an engineering solution to solve, in essence, a paper management problem. And in 1975, the Veteran Affairs, or VA, actually created a rather remarkable system called VISTA. And the system actually was the very first time that you saw clinical, financial, and administrative systems all integrated together. And it sort of made sense, right? Because the VA is a closed system. It's a closed system. It manages all the payments. It manages all of the procurement. It manages all of the supplies. It manages all of the different aspects of it. It never had to go outside. So in many respects, it ended up becoming a really quite an impressive system that was tweaked to meet the needs of that particular population. And last count, at least over 9 million veterans have used this system, or were part of this system. Now, the system is on its way out, but at the moment, if you think about it, in 1975, what a remarkable thing to do, to combine all of these functionality, not just a file cabinet anymore, but actually a way to manage the hospital. So then in 1979, you start to see the beginning of what we would consider the largest players in the electronic health space, and they are hospital-based. So Judy Faulkner founds Human Systems Computing, which is later known as Epic Systems, and then also in 79, Cerner comes out. Cerner actually has an interesting story in the sense that it was founded by 3 management consultants who decided they were going to use software to fix the billing problems because one of their friends had a medical practice where they knew the owner, and they had a little bit of a problem. They said, "Oh, we'll come and help fix it for you because we're looking for projects because we just started a little consulting firm and we don't have any clients." And then that was really what began Cerner. But what's interesting is that in this time frame, it's all engineering type of solutions. Everything is just simply about connecting pieces of information, putting it into central repositories. So outside of the VA, all of these types of systems look very similar to one another, and they're all just simply going after the different hospitals one by one. And it isn't until 1991 that someone actually writes down kind of like what actually constitutes a computer-based patient record. And the Institute of Medicine took it upon themselves in 1991 to do that. And when they did that, something interesting happened. You started seeing a lot of electronic medical records start to come out because in some sense you've defined the specs of what this was supposed to be. And now you have ambulatory physicians that people are wanting to go after, but most of these EMRs are local. They're within one county of within a state. They're within one city. They're in whatever, and they don't even have the full city. These are very clunky systems, oftentimes built with everything being local, including whatever network or whatever storage exists there, but they are developing, and they're expensive to install, and they're not great in terms of interface. But the market sort of works itself out over time, right? Things should get better. Technology gets better, interfaces get better, user needs get better, and we start to move in that direction. And then something happens in 96. In 1996, HIPAA passes. And the funny thing about HIPAA is everyone's like, well, HIPAA, that's about privacy. What does that have to do with electronic records? It has everything to do with electronic records because the reason HIPAA exists is partially due to a behavior that has been happening in the marketplace. In the marketplace of that time period, if you wanted insurance and you had a pre-existing condition, and remember this was also a time period when we were dealing with HIV, when we were dealing with a lot of very expensive unknown types of diseases, and people could be denied insurance for it. And so there was a desire by the administration in around the 1992 when the Clinton administration came out to try and solve this problem for the American public by trying to begin to start creating insurance reform and by trying to focus on the idea that we shouldn't be discriminating against people for the diseases that they have. But there is also a fear because in 1995 when the internet becomes widely available, people start worrying about the fact that, well, maybe you can get my data, and maybe people are going to be able to now have access to information of which they can continue to discriminate. So as part of HIPAA, which is the health, information portability, insurance portability act, it actually incorporates for the first time this concept of patient privacy. And it specifically mentions the concept of it being electronic data. So you're starting to see that people are thinking, wait a second, there is data being captured, and we've got to be careful with it because we may actually use this inadvertently to start to discriminate. But the timing is interesting, right? Because 1996 is a year after the internet becomes widely available, and this is before mobile technologies. This is before many things start to come around. There's certainly no concept of sharing information voluntarily, right? We do not have Facebook. We do not have any social media. We barely have anything our phones are used purely to make phone calls. We're not doing anything else special beyond that. And if you think about it, this is a law that while it puts into place this concept that people cannot discriminate against you, it doesn't evolve fast enough. Technology changes so quickly after this that it becomes very difficult for HIPAA, who might have been a very necessary concept, to not ultimately become a bit of a nuisance when it comes to dealing with information systems as they get larger. And you'll sort of see that over time, there will be legislation that will continue to pass that will try to basically make up for the holes in HIPAA that were not anticipated, but it will still always be reactive, which again goes back to you got to understand policy before you can understand the business of healthcare. And then, of course, as earlier as I mentioned, you had all these small EMRs developing up locally. In 1997, Glenn Tullman takes over Allscripts and starts to do something that no other had done before, which was he starts rolling up the EMR vendors and starts buying them up, pulling them together, merges them with a practice management vendor in 2010. And that is the company Veradigm today, which is in essence basically built through a roll-up of all the small ambulatory vendors. They obviously are not the only ones anymore, but at that time that was a bold move because none of these systems could even integrate at that time. So it was simply a holding company, a lot of different systems. And then finally, in about 2004, we start to see the beginning of an establishing of certification and a push for interoperability. We have multiple systems out there. None of them can talk to one another. It suddenly becomes the perspective of the federal government that we now need a system. We need standards. We need these organizations to start being able to talk to one another, and we need these systems to start talking to each other. So let me ask you another question. What do you think the difference is between an electronic medical record and an electronic health record? We do use them interchangeably, EMRs, EHRs. Want to hazard a guess? Okay. Difference has to do with perspective. EMRs in the 1990s were really very practice-centric. They focused very much on the patient. Remember, think about the fact that we were talking about a medical filing cabinet. We were talking about the information that had to do with the clinical care of a patient, their problem lists, their health status. It was meant to basically provide the capability to solve problems. Let me explain what I think is happening to this patient. And there's another specialist who comes and reads this chart and sort of also opines on it. It is an opportunity. It's it's almost a workflow type of a product. And that's what an electronic medical record is. But what happens a long time is when certification starts to become part of it, when the idea of interoperability starts to become a bigger concept, and that these systems have to start talking to one another. But more importantly, that we need to use these systems to help us bill accurately and be able to get paid accurately. And the transactional aspect of healthcare starts to marry into these electronic medical records. We turn this into something that's more system-centric, and therefore they become the electronic health record. And that is when the change occurs. We went from predominantly something that was about medical care for a patient, and also within the four walls of maybe an organization, to now moving over to a system-wide way of thinking, but very much including the transactions, payments, billing, as well as connections with all the other pieces of information. And that's why we call them the electronic health records. So now, using this electronic health record concept where you're no longer by yourself, but you're part of something bigger, you got to get people to use it. You really do, and here's the crazy thing. We had all this opportunity, all these things were happening. You had vendors out there, you had people selling better and better systems in theory, right? They now were connected to practice management, they were connected to capabilities that might have some of the financial, kind of think back to the VA, a little bit more like that type of system. But was it really gaining traction? It really wasn't. It was really, really poor in the beginning. It barely hit 10%. Okay, so about 10 years after you start seeing EHRs in a very sort of commercial setting, 10%. Okay, no one wants it. No one wants it. Some people argue it's because the tech wasn't ready, it wasn't like user friendly, but it was really because it was expensive and it wasn't tied very well into the workflow and it was hard to integrate and nobody wanted to stop their work to basically put in a system and be trained on a system. And so the federal government tried to figure out ways to try and encourage it. Grants, that Office of the National Coordinator of Health Information Technology that was established in 2004, is trying to come up with lots of different ways, lots of experiments. Come on, everyone. Why don't we use this? This is going to be the backbone. If we don't have this, if there ever ends up being a security issue, if there ever ends up being an issue around us needing information, medical safety, medical errors, and oh, by the way, we can also take the waste out of a system. Why aren't you all adopting it? Nobody was adopting it. Really, really slow. And then, again, you need to understand policy before you understand the business of healthcare. In 2008, the housing crisis that happens here causes a massive market crash and a global recession. And that is the moment that the federal government moves in. Because as part of the American Recovery and Reinvestment Act in 2009, there's an entire section, which I think you learned about earlier today, high tech. It's an opportunity to maybe begin to encourage industries that might have had a lot of trouble because of this recession and because of the fact that there was this crash, to help them out. And it gives the federal government an opportunity to try and push EHR adoption under the perspective that it would become the linchpin of a digital health infrastructure. And then, of course, in 2009 with high tech, the way they did it was through a series of incentives and penalties. And then by 2010, so a year later, Affordable Care Act, which is Obamacare, starts to talk about value-based care, about what you can do with this data. If everyone was on an EHR, if there was the ability for us to look at all this data, what could we do with it? We could begin to better allocate resources. But high tech and meaningful use, honestly, for those of us who were there during this time period, we all still have PTSD from this. And part of the reason we do is because it was really such a non-market type of move. Right? It really was. It was this concept that we used a bludgeon. We said, meaningful use. What does that mean? That means that if you are using technology, it has to be certified by the U.S. Health and Human Services. And it has to have specific reporting capabilities. And guess what, physicians and hospitals? You've got 5 years. And the numbers are going to change on you in these 5 years. And you have to adopt and you have to demonstrate meaningful use. Or else you're not keeping your Medicaid or your Medicare reimbursement levels. We're going to hit you in the pocket. And we're also going to give you the ability to adopt this, because we understand that. But we're going to really push you to do this, because we believe this is a national an opportunity. We believe this is for national security. We believe that if you certify this, you will get better capabilities for interoperability. But let's remember, what happens when you put a certification in the game? The vendors have to meet that certification capability. And who are better positioned to meet certification capabilities? But the companies that have the most money. They can meet requirements. And so it creates this very interesting sort of market distortion. The incentives, I think you learned a little bit about earlier today, is $27 billion paid out over 10 years. Physicians were given anywhere between 4 to 6 years to get these incentive payments for adopting. The money was meant to offset the cost of implementing EHRs. And hospitals, while they do really well, they're basically told, You're gonna get 2 million, it's gonna keep climbing up to about 6.37 in the end, depending on when you start. Okay, so you start late, it's gonna be less. You start earlier, it's gonna be more. What's gonna happen is you're gonna get this annual payment to keep it up. The goal was meant to create the cash flow available for you to be able to adopt the systems. But that cash flow doesn't go into necessarily the pockets of the physician, and it doesn't necessarily go into the pockets of the hospital. It goes into the vendors' pockets of the people who are providing the EHRs. Okay, so this is the biggest boondoggle for the EHR industry at this point in time, which makes sense, right? You know, the government says, I need to have this everywhere. I need to pay people who do this. We're going to give you the money to do it. But oh, by the way, we're going to penalize you if you don't. So if you were a physician and you didn't adopt a certified EHR by 2015, 1% of your Medicare payment would go down, and then it would go up to 3%, and then it would go to 5%, and then it would plateau out. So basically we're saying we are not going to let you be able to make the money that you used to be able to make if you don't adopt it. Oh, and by the way, inside of all of these new systems, we're also going to beef up HIPAA even more in terms of trying to meet some of the technological changes. And if you violate it, we have a series of civil penalties and fines on you, including jail time, and you might possibly lose Medicare or Medicaid. Now, think about what this means as a physician. If you are not adopting it, you're going to get penalized. If you do adopt it, okay, well, we'll offset the cost of your implementation. Doesn't change the fact that you have to put the time and effort to learn how to do this. And then on top of that, HIPAA violations. How does that work? If I look up a patient that is not my patient, maybe it's a family member, I took a look at their record. I'm not saying that that's the right thing to do, but you could see how that would be something that someone might do. That's a HIPAA violation. The ability to start looking at information, to start gathering information, to think about what might be happening. These are not your patients. It's a HIPAA violation. So all of a sudden, you are now dealing with policies that have made the workflow different and difficult. Now you have to think about how to do it. Now you have to rationalize what you have to do. Oh, and by the way, you're not going to make as much money if you don't get this in, and you never mind the amount of time you might have lost in implementing. And so naturally, the EHR vendors grew the biggest during this time period. Epic makes off with this. So Oracle Health, which is Cerner today, or back then, also does. Many of these EHR vendors who existed at that time frame made off quite well with something some of them just didn't expect. But once they recognized there were these subsidies, it was going to be the biggest race to get as many physicians and hospitals on board. And that's why you ended up with as many vendors as you did in that time period. But also over time, what would happen is people would start to shed certain parts of their business. Nonetheless, everyone kind of went through that. Do you remember how I mentioned that Glenn Tolman was basically rolling up all those EHRs and basically merged with a practice management system in 2010? That was largely to get access to this particular sort of financial incentive. It wasn't wrong, it wasn't illegal, right? It was there out there. If you had the system to prove that you could do all of these different capabilities from e-prescribing to integration to administrative functions to the ability to work through your system and prove safety, you were going to go for it. And in fact, I think GE was actually perhaps the most egregious of them all because they actually priced their product for the same amount of money as the physician was going to receive as an incentive. So those are the stories from that time period. Anyway, I think you saw this slide earlier, but you can see what happened, right? Drop the incentives in, drop the penalties in, do it around 2008, and look at what happens. Your 10% suddenly becomes 96%. Your 18%, 17, 18% of your physician population makes it up to about 78%. You're probably wondering what that gap is in between. That 78% and that 96%, because remember, there's still independent physicians out there. There are still clinics out there, and there isn't an incentive payment anymore, and there isn't a penalty anymore. And at this point in time, there is still a percentage of physicians who've decided to remain old school, and have actually, a number of them are also concierge medicine physicians who feel that in large respect, they don't have to. It's a choice now. So this is about where you've come out. But it worked. It totally worked in terms of an incentive and a penalty game, and we did end up building, in essence, the backbone of a digital infrastructure. So really, if you think about it, incentives, they drive behavior. Regulation, it favors the incumbent, right? You know, Epic was already there, Cerner was already there. In a functioning marketplace, customer workflow and user experience should have been the driver of success. My product should have been the one you wanted because it most met your needs, not because it happened to fulfill a series of requirements and then you came up with a deal for me. And here's the one other aspect that I think people didn't quite realize. This is really an unintended consequence that happened. When you marry electronic health record data with administrative or any kind of like financial data, you have to code for it. You have to code those diagnoses. You have to code what you do. And the thing about it is the coding for billing is not the same as coding for research. What do I mean by that? I'm going to give you an example. I can code for the fact that you have dementia, or no, how about this one? That you have Parkinson's disease. I can code for the fact that you have certain drugs that you take, right? I can even code for the services that I might be able to prescribe you for. But what I won't code for are those little tests that physicians might do, which is like, I want to see you do a 6-minute walk test in front of me. I want to see if you can answer my mini mental health questions. I want to know what's really happening to you as a patient in the progress of your disease so I can figure out how fast it's going and how I can help you. That is not coded because that is not billed for, because that is not paid for. So all that data that we have pushed an entire system for isn't exactly designed for us to understand the care for a patient, the progress of a patient, populations of patients, or even how we can improve. And there's the interesting gap that exists because it's driven for billing, for payment. This is how we figure out things like value-based care, whether there's something is getting paid in what we value, things like that, but they are only the things we measure that matter to someone who is selling something, okay? So this is kind of one of the big myths that we might have integrated, we might have pushed a lot of data collection, but how good is that data? So this is one of the ways of thinking about EHRs. While it may be the linchpin of the digital health system, it's actually the backbone of our revenue cycle management in the healthcare system. And some of the things that have happened because of this is that, and I'm sure some of these look very familiar to you, physicians, in the course of having to document information that sometimes was more valued for the billing than for the care of a patient, became what we call service providers. We started referring to them as service providers in the system. And they were not necessarily recognized as investigators or research. I just mentioned how coding for billing doesn't tell a complete story. I can tell you something interesting. Claims data is the #1 data source that researchers use today to figure out real-world analysis in order to add to clinical trials. And they are triangulating. They are imputing values at the moment. They are hiring people to read documents to try and understand, did you kind of run that test based on what you wrote here? Because it's obviously not billed somewhere, all right? We have these things called financial toxicity leads to perverse behavior. What do I mean by that? Physicians suddenly have a reason to sometimes lie on the electronic health record because if they know that a particular diagnosis or a particular treatment is going to be denied by the insurance, they will come up with a different code. And they have the ability to come up with a different diagnosis in order to get that because maybe it gets covered by insurance in one versus another. All of a sudden you are changing behavior. So the care that is being given is what is being thought of is the financial implications, the billing implications, the fact that information you might be capturing in a note isn't going to be useful from a billing perspective, but is useful for you to care. And we wonder why EHRs are part of what contribute to physician burnout. And perhaps why that graph that you were showing about why 42% don't necessarily think EHRs lead you to better tools or better anything because really honestly, up to date, it hasn't been that great, right? Now, that's not to say there hasn't been any gains, because I don't want them to think that I'm being overly negative about it, but I think it's to understand that in a market, when you win because your product meets your needs or meets your workflow, you can end up with something that aligns with what somebody who's using it wants to achieve. But when it is distorted because you have created a different reason for why someone will gain business because someone else is paying for it, you can end up with situations like this where you won't necessarily, where the end result shows up years later. And you wonder why it's so difficult to navigate where every piece of information resides. Because every piece of information about you as a patient isn't necessarily captured in a billing code, and it's not captured in any one particular place, it's captured in multiple places. It is put together like a detective puts together pieces. And you as a patient, it's very difficult. How are you going to be that detective to pull it together? And never mind the fact that the Cerner data and the Epic data don't talk to each other, right? That you're in different systems. So structurally, it's difficult, but also from even a templating point of view, it's also difficult. How do you put these pieces together? So the question then is it possible? Can we bridge this gap? This is kind of where we have tried to come up with ways to actually bridge what we realized in the 2010s that we had built, which was that we had a billing structure and we had a research structure that were two separate ecosystems and one could not help the other. But in 2016, the 21st Century Cures Act gets passed, and it's a very far-reaching act. And more importantly, it's the first time you hear about this concept of real-world data and evidence. And really, the pure concept of it, and I won't go into this too late because it's a class in its own right, is that patient data collected in routine care that's captured in the EHR can be analyzed to provide supplementary evidence for clinical trials. We might be able to see if that drug works better in one group of population versus another. But in order for that data to be even useful enough, it does still require work. It still requires imputing information. It still involves basically abstracting what someone meant. It means generating cohorts to compare. There's a lot of statistical analysis involved in it. But if you can do it, you have basically created a new source of clinical research data. And this act itself focuses an entire industry, both in the health information tech space and pharma and biotech and the vendors in the clinical trial space and the contract research organizations to suddenly focus on the value of this clinical data and discover that it's not as good as it could have been. Again, legislation and policy aren't always the reality on the ground. We all know this as patients. We know we deal with different systems, different permissions, multimodal data. What is multimodal data? Those are your x-rays, your pathology reports, your lab results. Most of those things are just attachments still. We are not that far from the electronic filing cabinet because we're still attaching PDFs inside of electronic records. This is multimodal data. And we have to de-identify it in order to do any research because that's basically HIPAA. It's driven that. So despite all these efforts toward interoperability and calls for a patient-centric ecosystem, we're still dealing with siloed data, not necessarily the best of data. Some of it is integrated reasonably well to be able to give us the opportunity to look at broad trends. Some of it is obviously very useful for how hospitals and clinics get paid. These systems do exist, but they were built for different reasons, and the usage were for different reasons, and the adoption, more importantly, was not driven because of the way a market would work. And so I'm going to conclude a little bit here and be able to give you a chance to ask questions, but by talking a little bit about generative AI and what does this mean? Why are people excited about generative AI? So I've already told you that the data is not great. It's not consistent, it's not complete. And what is generative AI? Generative AI are built on models, on learning models, who in theory have to be trained on data. But the data's got to be good data, because if it's not, it's going to end up making a lot of mistakes. It already does make mistakes, but if you think about it, It's not that easy to get this consistent and complete data. It's one of the reasons why a number of these large AI companies are out there directly paying organizations who are trying to clean data for training data, because the data doesn't by itself exist in a way that's easy to use to feed a model. Applications. Before using generative AI, to think about the fact that they want to capture inside of a patient encounter information that might have been lost. So they're using these recording devices and transcribing them into, like, these are known as ambient scribe or AI scribe. But I've been talking to physicians over the last month, and many of them don't like ambient scribe, just as much as there are many of them who do love it because it has saved them a lot of documentation. And the ones who don't love it, I've asked them a little bit about why. And they said something which I imagine is probably what they also would have said 20 years ago, 25 years ago around paper, which is the fact that what gets captured in an encounter isn't necessarily capturing their thought process. So what occurs is, let's say I am worried about you as a patient, and I think that something's up with you, like you're suddenly forgetting things. So I start having a conversation with you. I'm not really asking you to tell me how you're feeling. I just start talking to you. I talk to you about your cat. Maybe I talk to you about your neighbor. It doesn't really matter, because I'm listening for how you're going to respond. And if you respond in a halting way, the scribe's not going to capture that. If you answer me slowly, or you answer me something that sounds somewhat reasonable but not really reasonable, it's not going to capture that. And what's even worse is what it sometimes does is it jumps ahead and thinks that you're just making chit chat and summarizes it like it's this wonderful conversation that you had with a patient. That is not, and then what happens is that physician goes back at the end of the day and has to correct the note. So now you might have taken some burden off, but you've created a different burden where you have to correct the AI. No, I asked that question because I was looking for whether speech patterns were changing. I was asking that question because I wanted to understand if their memory was changing. I asked that question because I wanted to see what their body language was. Were they hiding something? Were they worried about something? All of these observational things disappear simply because it was thought of as just simply like, oh, it's a documentation problem we're trying to solve. Again, workflow, huge part of this aspect. Generative AI has a role, but not if it doesn't think about the workflow. Not if we don't apply it that. And then finally, I think someone in here said we do not have reliable processes. That's hard to put an agentic AI in the game if you do not have a reliable process. So I think that these are things to think about as we start to develop generative AI, that in the case of healthcare, we're not only thinking about data, workflow, and process. We have one more thing to worry about, and that is we have to think about patient privacy. How are we preventing ourselves from copying and pasting pieces of information all over a system? Because if you think about it, that is kind of how you can use AI to copy and paste, but in some sense, we may be violating HIPAA again. So again, how does this all work together? This is going to require some thought. And this is what I would say is the collective responsibility from all of us. In fact, with the health IT system we have today, is how will we apply generative AI? Again, in a responsible way, what will you need to create a model that you can depend on? What application do you want to put it in? Is it meant for a care setting, an administrative setting, or a research setting? And who's going to provide the tools? Are we going to have Epic and Cerner provide these tools embedded inside their EHRs, which aren't necessarily designed for your workflow, and it allows them to maintain dominance? But maybe that is our only choice. Is it big tech? I don't have time to go through it very much, but I can tell you big tech has tried to get in healthcare so many times and failed so many times. But they also have to justify the ROI of generative AI. So is this another place they will come back into again? Or is it going to come from small startups solving discrete problems? How will those get knitted together? Or are they just going to be the bridges that are going to happen across this thing? And how do we think about this? Then maybe more importantly, we should be asking ourselves the question, because healthcare is so personal, it's so fundamental. Health IT was meant to just be a digital infrastructure to support us, but really at the end of the day, it's about care, it's about research, it's about population health, it's about personal health, And if you think about this, and it's about wellness, do the tools that we put into our already not so great healthcare IT system augmenting our human capabilities? Are they preserving human dignity, respecting personal agency, supporting professional judgment? Remember, physicians are a little bit more like providers than they are necessarily physicians. And are they bridging knowledge? Are we going to be able to use AI to maybe extract data a little faster? Can we actually turn what we see as an unstructured clinical note into a series of tests that we now know we actually did? Lots of different cool possibilities, but the point is, how will we do it and how will we think about it? What happens next? I think everyone has to get more involved, but I'll tell you what happens next. My book comes out, so in any event, I have some postcards in the back if you're interested. But in all seriousness, I'd really love people to start having these conversations. How generative AI is applied in healthcare, particularly with a not great digital health infrastructure or digital infrastructure in general, has now become a much bigger collective issue. It's not about waiting to see if the health system itself or the healthcare IT system will somehow correct itself because it's never had an incentive or the structural sort of setup to actually improve. 25 years and it sort of is the mess that it kind of is right now, even though it does provide some value. Drop AI into the game, and guess what? We could actually end up with something amazing, or we could end up with something terrible. And the point is, this becomes something that everyone should be more involved in and thinking about. So with that, thank you for your time. I have time for questions.
What changes do you think could be made to HIPAA to make information be able to travel more freely and be more effective in trying to kind of lower costs throughout the system?
So HIPAA's entire goal was really to help patients, right? And if you think about it, it does sort of say something interesting. There might be a chance to sort of switch who is in charge. I think if patients have the ability to be able to put their data together, I think it starts to solve a lot of the issues around HIPAA. But I also think that by having that agency, patients should also be able to give permission as to who can have access to it. Do I allow this to be used for research? Do I allow this to be for someone to see? We already do that in an interesting way. You do have the ability to assign the rights over, but it's hard. It's not easy to find. A lot of times people are compromised and you can't have the ability to get information. In fact, one of the biggest workarounds is this whole concept of power of attorney, right? People do this for, there are these legal forms that come out where if you are a parent with children in college and you're worried that your child may end up in a certain situation where they may be incapacitated or unable to do anything, you can't access their data. You can't help them. You have no say in that game. And for a parent, that's one of the most frightening thoughts. So there's this concept that Mama Bear Legal came out with, which was these power of attorney documents that allow someone to assign it over. But now that's kind of crazy, right? I've just assigned all these rights to you so that you can have access to it on the possibility that something terrible could happen. Or I'm having to file a power of attorney document for an elderly parent who might be suffering cognitive decline, just so I can have a say in that. I think the fact is that we've not created flexibility in terms of HIPAA, in terms of talking about where may there be circumstances in which it might be a break glass moment. And I think that where this will only come from is if patients have the ability, or if we as individuals have more say in our data, the ability to pull our data together, the ability to argue for what we want it used for, or these questions are presented to us, it will be hard to change legislation without voices of that nature. But that's hard, right? Because those tools don't totally always exist. Yes.
I'm curious about what you think about the consolidation of capabilities for systems like Epic or Cerner or Paradigm. Do you think that more innovation will come from just these systems getting bigger, with things like ambient scribes? I know Epic is trying to kind of expand that space. Or do you think it's better to have these smaller startups being the ones that are presenting these solutions to work with the larger systems?
So I am biased toward the smaller startups. And I actually was the interim CEO of Veradigm for 6 months, which is sort of funny that I would have this perspective. But I honestly believe that the largest players have not necessarily used their position well over the years, in the sense that they have continued to try and keep you within a universe. And while the software may work, and I think I heard Dr. Chan talk a little bit about the Acquired podcast on Epic, there is this sort of perspective that this is a universe. Everything is in here. It all works. The software works. Why would you ever want to leave to go anywhere else? Except the fact is there are other places that will be using other systems. So I think what ends up happening is you just take the walled gardens and take them up even higher if all of the capabilities are kept within the large systems. So they have not. Half of the legislation that has passed has been trying to get people to share data, right? So if you just make it more and more of a closed universe, don't you just make it harder and harder for them to share? Even the most recent announcement this summer about this idea that we were going to create a patient-centric ecosystem, and the White House got 60 different vendors and different organizations to commit to it. It's all voluntary. And so we've already seen what's happened with voluntary. They won't necessarily voluntarily share. And so I don't think it necessarily helps. I think it's better to keep the big on sort of like worried by making sure that there are other companies out there who are going to force them to be better, almost create the market. So I don't think it's helpful to make the market or to solidify or consolidate the market that was bumped up because of subsidies from 15 years ago.
Kind of on a conversation about medical records, but more, I guess, on the patient side, when you were talking about like medical record aggregators. What do you think have been the biggest challenges for those smaller companies, whether that be One Record or Chart Request or Picnic Health, and creating and aggregating value for patients in terms of their medical records in the system that we have now?
So part of this is actually the way data is stored. Okay, so some of it is just bad behavior, right? Like I'm not sharing with you, I'm not giving you access to information, but part of it is really just the data. So if you look at a medical record today, one portion of it is structured data, and almost all the rest of it is unstructured data. So the structured data is demographics, address, things that are easy, diagnosis codes, all the things that are easy. That's the only data that's available that people sell, because they can de-identify it and they can sell it in big aggregates, and that's a lot of the information people get access to. What every EHR holds on to is the unstructured data. Those are the clinical notes. That's where the thinking is. That's where the random sort of like infusion rates or, walk tests or any other kind of Minty Metal status tests. All those information is captured there. That information is actually very hard to liberate. It does require abstractors, clinically trained abstractors, to pull that information out. Now, there are new tools. There are new AI-oriented tools that are focusing on how to abstract the data, to start looking for the patients that have certain things. But that data is actually not easy to access, both in terms of people will not sell it and also because it's hard to sort of pull meaning out of it. So I think what makes it difficult for small startups is the only data that even they can access, as long as everyone else, is still just the structured data, which means that the newer startups have to think about this differently. Maybe they go to patients and they say, I offer you a tool to pull it all together, right? And you might have to go and stand outside a door, and you might have to go get like some information from here and there, but we will make it easy for you to upload it because we're going to connect you to the following things. That's one way to solve that problem. Another way to solve that problem is that you start using research groups to start to collect certain types of information and ensure that that's the information that someone is starting to collect on their own. But part of the reason that it's so difficult for small startups is because they can't access the data of the EHRs. They can't access these large sets. More importantly, even if they could, they only can access the structured data.
The Regulate Act, the 21st Century Real World Data one.
Yeah. Secure Act, yeah. It's a mouthful.
I have a question on just like the usage of that and
Yeah.
how it's been applied recently. Like, are there any entities that primarily use the real world data? Are they trying to like use it for drug discovery or mostly like validating old research practices or?
No, it's a great question. it's a really wide-reaching act. There are multiple parts to this act, but as far as the part around real-world data and real-world evidence, what it did was it gave permission for the idea of utilizing and exploring whether this data could be used for FDA or to approve drugs. And that is actually some of the earliest uses of real-world data. So this has been going on for almost 10 years now. So we've been dealing with real-world data and real-world evidence. They're not quite the same thing because data is just the raw data, and evidence is when it starts to become useful because it's packaged in a cohort, because it has certain characteristics, things like that, and that you can actually run statistical analysis on it and know that you're actually seeing a cause and effect, or seeing a true correlation versus just, oh, incidentally, this person had a sandwich when they took this drug. So, and we started off in the very beginning with the FDA by using the data for rare cancers, for rare diseases, because there was nothing else, right? You couldn't pull a control group, you couldn't do anything else, so you had to use whatever information existed out there, and there was so little of it that was the first place FDA was willing to accept real-world evidence. And then the second place that we're willing to accept it was these things that we call synthetic control arms, which was basically, if you were dealing with a rare disease, it was hard to find a control group. So you would manufacture a control group by using patient data to create, in essence, a synthetic control group as if they had been the people you had selected to not give them anything, and compare them against someone who had that. So we actually have been using it. It is not always part of an approval. Sometimes it's just part of understanding. So we run real-world evidence type as a supplement most of the time, not as a replacement yet for clinical trials. But it is still, nonetheless, a really worthwhile area. However, it's expensive, more expensive than people realize. It's not as expensive as running a clinical trial. That will run you very high. That will run you 800 million, whatever. That will run you in those high numbers. But to run a real-world evidence study, we've got a medium size for like a phase 2 trial, you will spend probably about $3 to $5 million to do that, and that's largely because you're managing the data. That's all data management that's driving that cost, and as well as access to that data. You had to buy it from somebody.
I really enjoyed what you had to say about kind of the idea of being an AI humanist. I want to know if there's other ways that you might be concerned that AI could be kind of failing to protect agency for people in the healthcare space that we should be thinking about.
Well, that's a great question, and it's a big topic too, right? I think it's not foolproof, but there is this concept of where's the human in the loop, right? In any process that's done, do you have a human in the loop? Do you have an expert in the loop? Or do you just daisy chain a series of sort of like agentic AI kind of movements of where one sort of generates the answer that tells another one to do a particular action that then generates another action? And I think one of the things that we've become a little too comfortable with is this idea that we can take a multi-step process and make it very sort of automated without thinking about where are the moments in which we might want to check along the way, or that we might want to stop it at a certain point to ask a certain question. Now, some would argue that's introducing friction into a problem, but there's a role for friction. Like I know that it always seems like we're always trying to create systems to take friction out of the game, but actually friction causes you to stop and think. And so I think that in some weird way, pushing for agency and pushing for being involved and pushing for sort of dignity and also just sort of the concepts that you have a say does mean introducing a little bit of friction into the mix, purely for the sake of not completely losing out to automation and losing to the complacency that comes from automation. So, but I think this is more of like a movement in some sense. It's like the slow medicine movement or the slow food movement. Might be a reason for going in that direction, slow things down.
I think we are out of time, so thank you so much for being here.